Ìṣẹ́yá, ìṣẹ́yá, ọmọ Ògùn. Ìṣẹ́yá, Elédùmarè, iṣẹ́ máa yá o.
In rural Nigeria, the journey to motherhood is filled with joy and anticipation. But for many women, this journey is shadowed by a stark reality. Nigeria accounts for nearly 20% of global maternal deaths. In rural communities like Odeda Local Government Area, a woman's chance of dying during childbirth is 1 in 22, one of the highest rates in the world. When complications arise, the difference between life and death often comes down to a single factor.
The maternal mortality rate in Ogun State is currently 194 per 100,000. Although it is slightly high, it's still one of the better ones in Nigeria. However, compared to the global figures and the global target of 70 per 100,000, we still have a long way to go.
So there's a wide body of research that shows that maternal mortality occurs due to a number of delays, 3 delays in particular. The delay in recognizing the need for care in a pregnant woman, the delay in reaching care once a decision has been made to seek it out, and then the delay on arrival at the healthcare facility and actually getting definitive care. So Emergency Response Africa, in collaboration with the Ogun State Ministry of Health, set out to address the second delay by providing access to transportation for women to get to emergency care when they needed it.
This program, Rural Maternal Health and Emergency Transport, is very important and needed in Ogun State. Before now, we have not been doing much in that aspect. Now that we had the program, we'll be able to know that a lot can be done to improve the access to the health facility. And this thing was conducted in one of our local government, Odeda Local Government in Ogun State.
In Odeda, where reliable emergency transportation is scarce, the second delay, reaching appropriate care, has remained a persistent barrier to saving mothers' lives.
The rural maternal health emergency transport is needed in order to address one of the delays that causes maternal mortalities. We all know in reproductive health there are 3 levels of delay for the woman to take a decision. After taking decision, the delay in moving from the house to the health facility, while the third one is at the facility level. So this intervention, the rural maternal health emergency transport, was instituted to ensure we cancel out the second level of delay and to make sure women get to the health facility for the necessary intervention in a seamless manner.
But one thing that was unique about Ogun State in particular was that there were certain statistics that the state needed to increase. So attendance at antenatal, the first and fourth antenatal care appointment, as well as skilled birth attendants. Those were 3 priorities of the Ogun State Ministry of Health. And so we adapted the solution to be able to provide free transportation to pregnant women to access their antenatal care appointments and emergency obstetric care when they need it. And the program has actually had significant impact in the pilot period on all of those metrics. So increasing first antenatal care attendance for women, increasing fourth antenatal care attendance, as well as skilled birth attendants. For the first time ever, the state is actively capturing data on the women that are accessing emergency obstetric care, and we're seeing lives saved.
Àwọn ẹ̀kọ́ tá a gbà ó pọ̀ lóríṣiríṣi lọ́pọ̀lọpọ̀, ṣùgbọ́n lára ẹ̀ tí ó jẹ́ kókó nínú ẹ̀ ni pé kí ni àpẹẹrẹ tá lè fi mọ̀ lára aláboyún ipò nídìí ìrànlọ́wọ́ bí emergency àbí nǹkan kan níbi kó máa da ẹ̀jẹ̀ lára tàbí kó máa da omi lára, tàbí kí bóyá ó wá sí clinic wá ṣe àyẹ̀wò bóyá ìfúnpá ẹ̀ lọ sókè, so àní jù bẹ́ẹ̀ lọ ṣá.
Àwọn ọ̀nà jíjìn tí ọ̀nà ò dáa tí wọ́n bá ti pè wá, ta ti gba ìpè wọn, ta ti mọ ibi tá à ń lọ, nítorí pé ọmọ àdúgbò ni àwa náà, kò sí ọ̀nà tó ṣàjòjì sí wa. A ti sọ fún ọ bó ṣe pè wá yẹn, ta ti gbé kọ́ wọn, a máa dọ́dọ̀ yín bóyá next 10 minutes o, ṣùgbọ́n ẹ mọ̀ pé ọ̀nà bíi báyìí kẹ̀kẹ́ yóò lè débẹ̀. ẹ máa bá wa manage, máa bá wa gbé nìyẹn díẹ̀díẹ̀ bọ̀ débi tí kẹ̀kẹ́ wa lè dùn sí láti wá fi gbé yín.
Transport affects the maternal program a lot because they normally face a lot of problem when they are coming down to the health center.
Wọ́n á gbé mi dáadáa. Tí wàá pè wọ́n pé kọ́ wá gbé mi ẹsẹ̀kẹsẹ̀ lọ́ máa ti dé, ọdẹ máa gbé mi wá, ọdẹ tún máa gbé mi lọ padà.
Ìgbà tí mo wá ní oyún gbà yẹn, so ara mi wí kí n jọ yẹn, tí mo jẹ́ pé wọ́n láti alọ́gẹ̀ health center. So mo yẹ pé ká fi kẹ̀kẹ́ òun àpẹ yẹn gbé mi láti ilé wá sí bíbá. Bàtà jẹ́ yẹ̀mí wò ń jọ yẹn, ẹni kò tí tó time, so wọ́n tún check mi ṣá, wọ́n jà tó ní kí àpẹ yẹn kó tó dá mi padà sí ilé padà.
Before the intervention of Emergency Response Africa era, we've not been doing maternal transport before the intervention of ERA.
To understand the real impact of Rural Maternal Health Emergency Transportation Initiative, we followed the story of Mrs. Olushola Omolola Iya twins and Afolabi Olajumoke from a remote village in Odeda.
Odeda Center ni mo bí àwọn ọmọ mi sí. Ìgbà tí mo fẹ́ bí àwọn twins, so ibi báyìí ni mo wá, dẹ̀ wọ́n bí báyìí. But ìgbà tí mo ní àwọn challenges kékeré kan, ó bá mi pè àwọn ní kẹ̀kẹ́ àwọn emergency kìíní yẹn. So àwọn ló wá fi ambulance gbé mi lọ sí General Hospital.
I actually came to the health center here, Alogi, to register for my antenatal. So my first time of coming, I actually met Mr. Shegun at the health center. So he spoke to every pregnant woman that day. He collected our phone numbers and our addresses also. So ever since then, Mr. Shegun had been punctual to carry us to our destination, from the clinic to our home, from our home to the clinic. As the emergency official man who carries us around.
With the ANC attendants, with the tricycle, most of them, they used to come late. They arrive early because we used to tell them that we have their numbers where they stay. So our drivers, they are always on ground on that the clinic days. So they will go and carry them and bring them to the facility for ANC, and they also take them back to their parents' house.
The most compelling part of this data that I have seen from the pilot stage is the number of the women who are now able to access regular antenatal care. In some areas, it's virtually double.
During the pilot, what we realized is that our first antenatal attendance rate actually went from 500 on average per month to about 700, which is a significant increase. When you look at it, when we calculated it, it was like a 62% increase. And the fourth antenatal attendance also increased by 32%. The stillbirth attendance, because the pilot was quite short, it was only about 3 months, but we also noticed an upward trajectory on the number of stillbirth attendants, that the births that were received and delivered in the facility.
Àyípadà wà dáadáa pé nígbà yìí àti nítorí ìjọ máa ṣe kẹ̀kẹ́ mọ́rúwá yẹn àjọ lọ sí lọ́dẹ́dá ni mo wà ń bẹ̀ níjọ yẹn. Ìjọ tó ti gbélé wa lọ́wọ́ tá a ti ń lò ní olódó, àyípadà wà. Àwọn èèyàn wa kò sí ìnira fún wọn láti bímọ. Bí yóò bá ṣe é ṣe lólódó ń bí, wọ́n á ti pé kẹ̀kẹ́, á gbé e lọ sọ́dẹ́dá general, á dẹ̀ bímọ, a ò sìnkú aláboyún mọ́. Láti gbà yẹn, àwọn ìyàwó wa wọ́n ń lóyún láyọ̀, wọ́n dẹ̀ ń bímọ láyọ̀. Ọmọ ń ké, ìyá ń fọhùn, a ò gbókù jáde nínú alààyè. Àǹfààní wa mẹ́rẹ̀pẹ̀tẹ̀.
Ohun tó ṣẹlẹ̀ ni pé nígbà tíjọba ti gbé ètò ìdè, àwọn aráàlú, ọba ìlú ni ó, ìjòyè ìlú ni ó, àwọn ìyálọ́jà ni ó, gbogbo wọn ni wọ́n fi ọwọ́ sí nítorí wípé ètò yẹn so èso rere, ó dẹ̀ mú lọ síwájú wá sí ìlú Odeda.
The Rural Maternal Health Emergency Transport Program was designed to address the second delay through a few key initiatives. First of all, we identified and selected individuals from within the target pilot community and trained them with basic skills to serve as community first responders. The second thing we did was we took the ambulance tricycles that were already existing in the community, refurbished them, got them into good working order, and paired them with the community first responders. Thirdly, we set up and deployed a very simple dispatch technology, a USSD solution that paired with phone calls to make it easy for the women to be able to reach the community responders. And then finally, we collaborated directly with the healthcare facilities to ensure that when a woman was being brought, they were ready to receive her and they were able to treat her in a manner that was respectful and positive and gave her a good experience overall.
I undergo 3 days training. 3 days training, how we are going to be taking care of the antenatal patients that they will bring here. So they give us the training how to take care of them when we first see them at the first time to attend to them.
Tí àwọn aláboyún wa tán bá dé láti, because most of them ọ̀nà wọn jìn, ìgbà míì tó bá fi máa dé ó ti máa rẹ̀ wọ́n, ẹlòmíì nínú wọn kò tún sí agbára fún wọn láti wá sí ọ̀dọ̀ wa ń bì báyìí pé kínní. So ìgbà tí program ní tí ìjọba ti tán gbé kalẹ̀ fún àwọn aláboyún wa tó dẹ̀ ti wá wà, so changes wà ẹ pé wọ́n máa tètè dé, so wọ́n máa lọ gbé wọn nílé, wọ́n dẹ̀ tún máa dá wọn padà, so changes wà dáadáa, wọ́n jẹ́ kán wá sí clinic dáadáa.
Every mother deserves the chance to safely bring new life into the world. In rural communities like Odeda, Rural Maternal Health Emergency Transportation Initiative is turning this basic right into reality, one emergency response at a time.
The biggest operational challenges the program faces are quite many, but I'll try to, as much as possible, to mention just a few. One will be the topography of the area. Just like most rural area in Nigeria, the road network is quite not motorable. So we are forced to use what available resources that we can just use to manage the network that we have there. Then secondly, the network interconnectivity in that community is quite not good enough. So it's limited our use of technology, and we have to fall back to using things that are quite easy for the people we are working with.
We believe that if our telecom sector really steps up within emergency services, we can see access increase to those who need it most.
A dúpẹ́ lọ́wọ́ ìjọba ìpínlẹ̀ Ogun àti Emergency Response Africa. A dúpẹ́ lọ́wọ́ wọn fún ètò ambulance tí wọ́n gbé wá fún wa. Wọ́n ṣe gan-an nítorí pé ẹlòmíì ní during labour tí kò bá tètè rí mọ́tò àbí ọ̀kadà, ìgbà míì wọ́n máa ń lose baby wọn tàbí àwọn gangan fúnra wọn ká pàdánù wọn. Ṣùgbọ́n látìgbà tí kẹ̀kẹ́ yìí ti dé, a dúpẹ́ wípé tá bá ti pè wọ́n lọ́wọ́ kan, ó dẹ̀ máa wá. So ìgbà míì nọ́ọ̀sì náà máa ń bá wa o, nọ́ọ̀sì máa bá kẹ̀kẹ́ yẹn wá tó ti máa fún ẹni yẹn ní ìtọ́jú kó tó dé sí center. A dúpẹ́ gidi gan. Mo dúpẹ́ lọ́wọ́ ìjọba ìpínlẹ̀ Ògùn. Wọ́n ṣe gan pẹ̀lú àwọn alọ́gẹ, àwọn tó ti ṣe ní alọ́gẹ health center náà. Mo dúpẹ́ lọ́wọ́ àwọn náà ṣe gan.
I'm using this opportunity to thank the emergency response for the care, for the support they've given us, most especially with the pregnant women. They've helped us in many ways through the transport and other things also. Really appreciate and thank you. May the Lord bless you and continue to bless your ways.
Mi ò ní ṣaláì má dúpẹ́ lọ́wọ́ Emergency Response Africa lábẹ́ ìpínlẹ̀ ìjọba Ogun State tí wọ́n gbé ètò kẹ̀kẹ́ ambulance yìí kalẹ̀. Nítorí pé bí kò bá sí ètò kẹ̀kẹ́ ambulance yìí, ọ̀pọ̀lọpọ̀ aláboyún ni wọ́n bá ti pàdánù àwọn ọmọ inú wọn tàbí kí wọ́n ti pàdánù ẹ̀mí wọn. Bákan náà ètò kẹ̀kẹ́ ambulance yìí ó ti ran ọ̀pọ̀lọpọ̀ aláboyún lọ́wọ́. Àwọn aláboyún tó jẹ́ wípé àti rìn láti inú ibi tó ń gbé bọ́ síta lọ sí ilé ìwòsàn ó máa ń ro wọ́n lójú. Kẹ̀kẹ́ ambulance yìí ó ti ran ọ̀pọ̀lọpọ̀ aláboyún lọ́wọ́. Ó dẹ̀ tún fún àwọn aláboyún míì ní ìtara láti lè máa lọ sí ilé ìwòsàn ní ìgbàkúgbà tó bá wù wọ́n, láì sí ìdààmú, láì sí wàhálà, láì sí ìnira. Pàápàá jùlọ àwọn aláboyún míì tó jẹ́ wípé ó ti ẹ̀kú díẹ̀ káàtó fún.
Maternal mortality is something that we cannot continue to ignore. in Nigeria. Nigeria contributes the third highest number. And simple interventions like the rural ambulance emergency transport system could make the difference for the Nigerian women.
By bridging the gap between homes and health facilities, between crisis and care, Rural Maternal Health Emergency Transportation Initiative offers a promise to rural mothers. You are not alone. When minutes matter most, help is on the way.
Ẹ̀yin ọmọ Ògùn, ẹ ṣe gírí, iṣẹ́ pọ̀ fún wa láti ṣe. Ọmọ rere kì í ṣáṣẹ́, ọmọ Ògùn kì í ṣọ̀lẹ. Ẹ bẹ̀rẹ̀ gbẹ́rù o, Ọlọ́run ń bẹ fún wa, ẹ tẹra mọ́ṣẹ́ o.